So it's my great pleasure to introduce Erica Barbazza, who's a PhD student visiting us from Amsterdam. She's part of a unique European health PhD training program called HealthPros, which she will describe in her presentation. She's based at the Academic Medical Center of the University of Amsterdam, and her research is really focused on the actionability of healthcare performance indicators, looking at what makes an indicator fit for purpose, and with the use of focus on specifically on primary care. And she's originally from Toronto, but she spent the past decade working abroad for the WHO and in countries in Central Asia and Europe. She did her MSc in International Health Policy at the London School of Economics and her previous degree at Western. And it's been wonderful hosting her here as part of her PhD program. And she'll be speaking today about some of the work she conducted in Canada, drawing on the international program of work that she'd started on primary care performance measurement. And fortunately, she's also going to explore some of the potential use of this work in light of the COVID-19 pandemic, so it's even more relevant. And I'm I'm going to turn over to her right now. And unfortunately, we won't have video. We're having some technical problems, but I'm really pleased it's been working smoothly so far, and we don't want to push our luck. So we'll be able to hear Erica. I'll turn it over to you. And we look forward to having a lecture and then a long time for question and answer at the end. So over to you.
Thanks, Sarah. This is Erica, and great, and I can move the slides. Well, it's great to connect virtually, and thanks to all of those that have joined online and to the NAO for the chance to share about a study we've been working on as part of my secondment to Toronto. Just before getting started, I wanted to acknowledge the larger study team that's behind this work, many of whom are on the call today. And this study team is made up of the partners of the HealthPros network and includes colleagues from different units and offices of the Canadian Institute for Health Information, CIHI, the University of Toronto, and University of Amsterdam. And also a big thanks to those that contributed to the work as an informant and for the work that they're surely doing now across the country. Now, just to give a quick overview of the talk and the scope of this virtual lecture, the aim of the presentation is to share some of the preliminary findings of our study on the current and potential use of EMR data for performance measurement in Canada. And this work has taken shape as part of my secondment, so that began in January and is wrapping up with the end of this month. And as we finalized the data collection, it was a chance to share back some of the initial findings. So in the topics to be covered include a brief description of our research and training network that is HealthPros for a bit of context. Then I'll briefly summarize about the study in terms of its scope and approach, and highlight some of the key findings and reflections. Now, one key disclaimer is that the fact that the findings are not yet validated, as that's part of the next steps of the study. And in terms of how the work will be disseminated, so as Sarah and Monica mentioned, it will be online. And we do also intend to share the findings in an open access peer-reviewed journal article, and I'll flag how to keep in touch with the HealthPros network to follow the release of this study and other similar ones that are being conducted. So briefly, for a bit of context, what is HealthPros? HealthPros is short for our EU-funded Marie Curie Innovative Training Network that is investing in a cohort of healthcare performance intelligence professionals, otherwise known as HealthPros Fellows. The network is really rooted in the thinking that data alone doesn't safeguard its meaningful use. So how can we create the competencies and professionalization of linking up all stages from an information need to decision making and taking action? It's the science of that process that HealthPros is founded on. Now, we're 14 fellows from varied continents and differing backgrounds, from clinicians to health economists, or in my case, a Canadian with a background in health sciences and international health policy. Now, there's 6 hosting universities, and that's in the top right here. And I'm based at the University of Amsterdam, like was mentioned, where I'm supervised by Professor Nick Lisinga, also the coordinator of the OECD Healthcare Quality Indicators Project, and Dr. Dion Kringos. And as you can see in the bottom right, there's a wide network of partnered organizations like CIHI and the University of Toronto that host fellows like myself for short research projects. And we're expected in our 3-year training program to complete 2 workplace-based research studies like this. And these studies are part of our overarching PhD portfolio, which in my case has a focus on optimizing the use of performance indicators with an emphasis on primary care. Now, just a last point on our research, again, for a bit of context of the network. So our PhDs are structured as a series of 5 to 6 different studies exploring our overarching research theme. And in my portfolio, I've been exploring at the outset the meaning of a fit for purpose and fit for use indicator. And these definitions we've used in the Canadian application and the study here. We've also conducted a study with WHO in the European region to explore indicators and data sources for measuring primary health care tailored to the high and middle income countries in the region. And then some country-specific applications have included in the Netherlands, together with the Dutch Institute for Health Services Research, NIVEL, a study looking to the use of primary care prescribing data and the ways and range and type of feedback loops and how that cascades the system. And in Canada, we've been looking specifically around the use of data for primary healthcare measurement with a focus on where and how EMR data is used. And that's the scope of our discussion today, but hopefully it's clear how it fits into our research network and the wider scope of studies. So what was the basis in our focus for looking to performance measurement in Canada? Well, the scope of our study was informed by a combination of factors. Specifically, we recognize that the organization and delivery of primary care, like the other health services in Canada, is mandated to the provinces and territories. And that to support this work, there are pan-Canadian primary healthcare indicators in place since 2006 and updated in 2012 by CIHI together with key stakeholders to encourage primary healthcare measurement and support meaningful comparisons. And since the outset, the electronic medical record, the EMRs, as the digital primary care information system, has been recognized as an important data source for measurement. And it holds a number of known advantages relative to other sources like administrative billing data or survey data, for example, for its timeliness and the granularity, and that allows for more robust patient profiles and point of care management of, on risk factors and conditions. But despite its advantages, realizing the full potential of EMR as a source is a challenge for a number of reasons, like its hybrid structured, semi-structured, unstructured data, but also some uniquely Canadian contextual factors like the varied ways that EMRs have been implemented across the country, different uses of standards among a number of factors. That said, though, the primary care EMR landscape in Canada is definitely changing. And in 2019, an average of 86% of participating Canadian GPs to the Commonwealth Fund International Health Policy Survey reported to use EMRs in their practice. And while that is still lower than the Commonwealth Fund average of 93%, that figure has doubled in the past decade, so up from 37% in 2009 and 73% in 2015. And it's a really exciting trend because as the adoption and sophistication of the EMRs advances, so has the potential for EMRs to serve as a source for performance measurement within and across the jurisdictions. But it really begs the question if in this changing information landscape, are EMRs in use as a data source for performance measurement? And that's what served as our guiding question for the study that was designed to take a systematic look to where and how EMR data is used and to explore some of the underpinning contextual factors that have enabled this in some instances or that are barriers to it in others. our ultimate aim was to get insights that might be of value to the other jurisdictions at earlier or simply different stages in that process. So more specifically, we had 3 key questions. First, to understand where EMR data is in use. Second, to look more closely at those uses and the indicators that are being sourced from EMRs. And third, to take stock of the insights that can be leveraged for enabling EMR data and its use. Now, the study was designed as a descriptive evaluation and policy analysis in a 2-stage approach. So we first looked across the 13 jurisdictions in Canada to get an up-to-date overview of current activities as far as possible, and then secondly, to specific use cases. And in terms of the data, we've relied on semi-structured interviews, and I'll speak more to that, document reviews of scientific and gray literature, and existing primary healthcare networks through CIHI. Now, just to clarify some key concepts or definitions we've applied, the first was how we defined what is meant by use, and for this we adapted a multi-level definition from an earlier study mentioned about the different levels, uses, and users of indicators. The root of these differences being the information needs and how that varies depending on the end target user with regards to the timeliness of the data, the type of analysis, the way it's received, etc. So we tried to unpack these by distinguishing between different levels and mapping the uses to these. The first being the micro clinical practice level, so further specifying between uses for individual performance improvement, so feedback to individual clinicians versus feedback to practices or teams. At the meso level, so uses for organizations or networks of care for longer term planning that targets more so management and executives. And at the macro level, so uses typically for policy and monitoring that's carried out by ministries and departments of health, etc. And then we also recognize the feed-in function of research as a cross-cutting use of performance data. And further, well, and also just to say, we expected from the outset to find the most activity at the research and micro level, and can confirm that's in fact what we found. And in terms of the fitness for use, so we applied an adapted indicator cycle that to describe the uses of the EMR sourced indicators, spanning from their selection to data collection and analysis through to the displaying of those results and reaching decision makers. And also we did apply a broad definition to indicator, so simply a measurement tool to provide information for achieving improvements in care and the processes by which care is provided. Now, just one last slide on setting up the study. So on the process itself, so in our first look across Canada for phase 1, we reached out to some more than 90 informants and engaged with more than 60. Our target was to have a minimum of 2 perspectives per province, so one stakeholder and be it ministry or other organizations, and one clinician researcher. And that was as high as 15 informants in the case of Ontario, for example. And we validated that broad scan with the joint meetings of existing networks, including an existing jurisdictional advisory group on primary care. And in the second phase, we zoomed into only those jurisdictions and use cases with examples of EMR data use, and here the focus took rather a look to the purposes of use described and the cycling of that use, so what measures and how the indicators are applied, and this is the phase and the analysis of where we are now at the moment. So to our first question on where primary healthcare EMR data is currently in use for performance measurement, just some highlights, and I'll try to illustrate these findings further. So our main finding from our initial pan-Canadian scan was the confirmation that yes, EMR data for performance measurement and improvement is in use. And these uses range from well-developed use cases to those that are in their earlier stages, some that have ended, and also a number of ad hoc examples or emerging practices. And the purposes of use are predominantly for practice level or micro level improvement with individual clinicians and teams, and for research, so to targeting practice-based research networks. And while there are a number of emerging practices of EMR use in a wider range of provinces, like in Quebec with links between the Compass and Par 3 initiative, or in Alberta with the Community Information Integration Initiative, or Saskatchewan with examples of select indicators, the well-established use cases are predominantly in Ontario, British Columbia, and Manitoba. And importantly, while we put a focus on the use of EMR data, there are a number of well-established uses of administrative and survey data, in particular at the macro system level for policy and system monitoring, and micro level, for example, through the panel feedback reporting. And in terms of the meso level, it would seem there are some emerging potential uses, like the optional use of EMR data for organizations to draw on EMRs in their annual quality improvement plans in Ontario. Otherwise, the Alliance for Healthier Communities, the data that can be aggregated from the community health centers demonstrates the planning and managerial use of EMR data with a longer term outlook. Now, just to illustrate these findings, so again, we recognize there are a number of initiatives, and we've shown some examples here that look to the administrative and survey data, though we've looked specifically here to the uses of EMR data as a source for the purposes of this study. And on the EMR side, we can see that in large part that activity is around the practice-focused initiatives at the micro level and organization uses, like the example of the Alliance mentioned. And at the system level, some more emerging or planned efforts in this area. And in terms of research, so networks like the Canadian Primary Care Sentinel Surveillance Network and its various branches like Utopian are examples of that research use, or emerging platforms like Pulsar in Quebec. Now, just to, in terms of the EMR uses identified that we've looked a bit further into to understand their cycling and the indicators drawn on. These examples are here. So there's one multi-jurisdictional example with the Canadian Primary Care Sentinel Surveillance Network, CIPSIN, a network of networks, and the first pan-Canadian primary care-based multi-disease surveillance system, and its data presentation tool, which is probably one of the more well-known initiatives and provides users with access to cleaned, processed, and structured EMR data for quality improvement and panel management, among other possible uses. In British Columbia, the Health Data Coalition is an example of a web-based dashboard that allows physicians to explore their performance against peers and provincial averages against a wide set of indicators. In Manitoba, we look to the primary care quality indicator set and their use in feedback reports to home clinics. And then there's a series of examples in Ontario, like the Ontario MD Insights for Care dashboard. This is an EMR integrated dashboard that allows for at-a-glance insights into the quality of the data and also the care that's being provided for patients to a reasonably widened set of indicators. The Alliance for Healthier Communities mentioned provides feedback specifically to its network of community health centers using its business intelligence and reporting tool that allows for some more interactive dashboards like on primary care, but also in practice reports. And lastly, the Data to Decision initiative of the Association of Family Health Teams offers great lessons and insights in terms of how this initiative was run. Now, to our second question about the uses of the indicators and specific measures that are being identified, that was the focus of our second question. And again, just some quick highlights. So the use cases range in their number of indicators from few, so approximately 30 to over 150 measures, and most consistently include indicators on chronic disease and prevention, and we'll discuss more on that. The data is predominantly extracted from the EMRs and stored centrally, aside from the example of Insights for Care. And the analysis vary in terms of their level of customization, though predominantly are presented as individual comparisons or an individual in comparison to their peers, and averages of participating practices or similar types of practices, as well as practices on similar vendors. And the delivery varies from standalone websites to those that are accessed through the EMR to reports, and also in terms of their timing or their frequency from daily to 3 months to 6 months in their cycles in terms of their updates. Now, I won't go into all the details of these cases, but just to get a sense of how they've been explored. So we used the adapted indicator cycle mentioned to see some of the differences around the indicators selected, so how they're analyzed, that format of the display and feedback, be it a dashboard or report, and also trying to take stock of evaluations of their impact where that's been studied, and the type of support that they've relied on for their implementation. And just to get a sense of the tools, so here are just some quick examples. On the left is the HDC Discover, the web-based dashboard, and its indicators by priority themes and how that's analyzed by physician, practice and province average. And on the right, the OMD with their Insights for Care initiative that interacts with the EMR and makes it possible to go deeper into the figures and identify specific patients in their panel. And I've linked to the websites on these where it's possible to get more details on the individual examples. And on the indicators themselves that are included within the tool. So we took a closer look to explore these and their common themes and areas of focus, and just to highlight some observations. So the indicators in large part have evolved from the pan-Canadian indicator set mentioned at the outset, and have adapted from that. The indicators that we looked to did not consistently align to a performance framework, so it made possible comparison only to the level of their themes. And as I mentioned, the sets really vary widely from few to many indicators. And in terms of the themes themselves, so the colors here signal the frequency of the indicator sub-themes, and these related to prevention, specifically around smoking, cancer, screening, obesity, and immunization. And second to that, on chronic diseases, specifically diabetes, but also COPD, mental health, and hypertension. And then some of the newer initiatives have included things like medication management and practice management. And to our last question, drawing on lessons from the jurisdictions and use cases, we looked to pull out some of the consistent themes as lessons for making use of the EMR data. So first, some initial reflections. Well, it's clear that the EMR landscape in Canada is dynamic. There's great interest of those in the field and momentum across the jurisdictions, and also a sense of increasing speed as some of the solutions and tools mature and advance in one jurisdiction and making it available to others. There's also definitely an appetite to learn from one another and exchange tools and standards that are available. And we did also try to study the themes related to contextual considerations, developmental considerations, or technical and methodological considerations that may offer insights for accelerating the process of use in other contexts. And specifically on that, so we tried to pull out some of those enabling considerations. And first around the contextual side, so those related to themes of governance, so the importance of having strong leadership to prioritize data collection, the advanced or matching that to the payment models, clarifying data protection and privacy, among others. The workforce considerations referred more so to the time and competencies and resources available. On the information side, factors like the stability of vendors, the saturation of the EMRs in the province, the technology solutions matching the context were also raised, and the importance of the organizational models, like the alignment between initiatives that are focused or tailored to the community health centers and the unique scope of services that they offer. And culture was also a frequently raised key enabler, so getting the the buy-in and also that shared sense of accountability and responsibility of GPs to their practice panel. Now, the developmental considerations referred more to the variation in efforts and priorities depending on the stage of development. So some jurisdictions are really at a starting out phase, where others are past piloting and testing ideas and now focused more on optimizing the information available and its use and for putting that into action. And then on the technical considerations, or the more methodological aspects, these refer to the content itself. So here, the importance of the clarity of the purpose of use. So being clear on the intended user and how the indicator should inform and be acted upon was clear. The need for the indicators to match delivery. So if working in teams, that teams are being measured among a number of other considerations that can hopefully offer insights into how to advance the potential of EMR data use in other contexts. I'm almost done and then can take some questions. But of course, in the current context, so we found ourselves reflecting on our findings in relation to COVID-19, and more specifically, what information needs we have for responding to a pandemic, and what are some of the ways that the EMRs can serve as a real-time source in an emergency situation. And definitely the different experiences from countries will offer insights for sort of future-proofing our systems and taking advantage of the potential of the information in primary care. But looking to some emerging themes and drawing from our network in the countries where HealthPros is working, highlighted some initial reflections on the different possible uses of EMR data. So for example, on the one hand, there's clear and unique value of the EMRs for panel management for chronic care needs and supporting physicians and practices to manage the follow-up with patients and ensure continuity in their care and refills of prescriptions, etc. And in terms of examples of how that can be used, I think there's great examples here at home, and these use cases described are possible or potential illustrations of the ways that the advanced use of EMRs can be uptaken and of value for managing chronic care patients in times like this. Another use of the primary care data could be for monitoring of trends like the huge increase in virtual care and drop off in regular care. And there's examples of that are interesting to follow, like the primary care national surveillance system of the Royal College of General Practitioners in England that have a mandate to monitor the occurrence of COVID in primary care. And it's included the introduction of new codes to their existing database, and I've included a link to that. And their protocol and how they've adapted their surveillance system is published online. And lastly, to the digital EMR is also the possibility to make data accessible for treatment for patients that go to hospital, though in many systems that type of exchange is a challenge, both on the technology and the privacy reasons. But there's examples, and like in the Dutch system with a COVID opt-in for a data exchange being recently adopted, that allows for patients to make their EMR record accessible in a context like we see now with COVID. Now, as a network, we are reflecting on different information needs at different stages of the pandemic in primary care, but also in hospitals and long-term care. And I've noted a forthcoming commentary by HealthPros that will speak more to this. And in wrapping up, so in my introduction, I noted that there will be different ways to keep in touch with the HealthPros network. So we have similar projects related to the use of performance data that have been conducted by other fellows. And the work I shared today was specifically with a focus on primary care. But two colleagues, Mirsha and Damir, also from the University of Amsterdam, were in Canada in 2019. And their research focused on hospitals, so looking to the use of performance data for decision-making in Ontario hospitals, and another study on long-term care looking to the effect of public reporting on long-term care indicators. And in 2021, another fellow, Kendall from the Santana School of Advanced Studies in Pisa, will be a visiting researcher, and his research is focused on patient-reported experience measures, and that will be looked to in the Canadian context. And I've included here the contact details for the fellows, but also the different ways to keep in touch via our website, Twitter, ResearchGate, where any new publications are posted. So with that, just a thanks for your attention, and happy to take any immediate comments or reflections. They've also included my email here. If you'd like to continue to discuss by email, that's any comments or reflections or feedback is most welcome. Thanks.
Thanks so much, Erica. This was a wonderful talk, a great sort of high-level view of the activity underway in Canada and some reflections in comparison to other jurisdictions. And so you've given us a lot to think about. We look forward to see your published work and the results of this and how it could inform the type of sort of alignment across the country that many people have been speaking about in terms of heightening our ability to use EMR data to improve system performance. So it's my great pleasure to thank you again and to wrap up this NAO lecture. And it's great to see participants from across the country and across the globe. One of the great advantages of this virtual platform, and it's been a delight having Erica here in Toronto with us. And so we're, we send her off safely back to Europe. And thank you so much for attending today. So we're going to wrap up for the day and have a great day and stay safe, everyone. Thank you.
Thank you.
Bye-bye.